Welcome to the critical thinking and nursing process of the high-risk postpartum client and family. Postpartum hemorrhage. In order to have a diagnosis of a postpartum hemorrhage, there needs to be a blood loss of greater than 500 cc's in the first 24 hours after a vaginal delivery and a blood loss of greater than 1,000 cc's in the first 24 hours after a C-section. You've seen this picture before. This is how you assess lochia. Unless, of course, you are weighing it, is pretty much the extent of the perineal pad saturation. Causes of a postpartum hemorrhage. Your book has figure 25.1. You know I like this ebook. Page 650. Postpartum causes, your most common. This is the most common challenge in postpartum. 1 out of 20 births. Sometimes it's just a mild postpartum hemorrhage, and sometimes is a really severe postpartum hemorrhage. Takes a little bit longer, for the hemorrhaging to stop. But the most frequent cause is going to be uterine atony. And this is when the muscles in the uterus do not contract. It's relaxation of the uterus, which then, of course, it relaxes, doesn't want to contract. So we call it hypotonia, H-Y-P-O, hypotonia. Now, a lot of times this is caused by chorioamniotitis, okay, that infection. Mom ruptures her amniotic membranes, and there's an infection. Okay, so that chorioamniotitis, or from tocolytics, okay? Let's say from us giving her breathine, us giving her magnesium sulfate that causes the uterus to relax. Lacerations is also a cause, maybe from the episiotomy, forceps, vacuum extraction. Retained placental fragments is another famous cause, and DIC. Symptoms, well, she's going to have decreased blood pressure. She's going to have increased shallow respirations. She will have a pale, clammy skin, increasing anxiety, increased heart rate, increased respiratory rate. She's going to present with obviously a boggy, large uterus that when you do a firm fundal massage, most likely you will be able to expel clots. And remember, because the bleeding is painless, okay, this is something that early recognition is absolutely critical. Okay, this bleeding is painless. Okay, the blood is going to be bright red. I can't say enough that early recognition is critical. What is a medical management? What are we going to do? Well, this is why you've got Pitocin to begin with, and there's standard orders, right after that baby's head is delivered, and Pitocin is going to start going for this mama. So the first and foremost, and I have another page number and another box here for you in your book before we start going with the medical management, is page 652, and it's box 25.4. So these are great boxes. These are great visuals for you to look at in your book. It goes through 25.4 goes through fundal massage, and they have some visuals for you as well. First and foremost, we want to prevent this postpartum hemorrhage. So we always want to do this firm fundal uterine massage to expel the clots. Okay, this is what we learned in postpartum, normal postpartum. You want to do your firm fundal massage of the uterine fundus to expel the clots. We want to make sure we have an empty bladder, right? We want to make sure we take vital signs, do pad counts, and make sure that mama drinks fluids. Okay. This is our baseline of what we learned in high risk in normal postpartum. And now this is the mom that she delivers and bleeds. Okay, and bleeds and bleeds. So here's Pitocin comes in. We're going to do in the labor room vigorous fundal massage. 15 seconds of vigorous fundal massage every minute. Okay, vigorous fundal massage to wake up that uterus. So first line, we always do Pitocin. Okay, because remember, the baby's born and that uterus still needs to contract to get this placenta out. So 10 to 20 units IM, or we could do IV continuous, 10 to 40 units. It'll be in 1,000 cc's of lactated ringers or normal saline, and it can run between 125 and 200 cc's an hour. Then we could do a bimanual compression. Okay, this is for medical management for our postpartum hemorrhage. And yes, it's as painful as the picture looks. You have to insert the fist into the vagina, and then you press the knuckles, not the nickels, the knuckles, against the interior side of the uterus, just like the picture, and the other hand of the abdomen. And what we want to do is we want to do this and release, and hopefully that uterus wakes up. Okay. At this point, when this is happening, we have to give meds. Okay, we cannot let this postpartum hemorrhage go. We have to take care of this. So I put in your slide Cytotec, Methergin, and Hemabate. Even though your book has Methergin as being the first one to go, Methergin and Hemabate, out in all of the hospitals right now, Cytotec is pretty much your first line, okay, with a postpartum hemorrhage, because it works very well. You do 800 to 1,000 micrograms rectally times 1, and it works very well. So usually that will take care of it. But if it doesn't, you can use Methergin. And Methergin has always had that potential where you have to be real careful if the patient's still hypertensive while all this is happening, because you don't want to do Methergin while their patient's still hypertensive. Even though they all cause an increase in blood pressure, you've got to be a little bit more careful with Methergin. Okay, you can give Methergin because Methergin really has a good reputation for providing sustained uterine contractions, which is what we want. Okay, and you could do a 0.2 milligrams dose IM, even IU, intrauterine. Okay, and you could do it every 2 to 4 hours. You could do up to 5 doses. So that Methergin has a good reputation. Cytotec is the one that is being used right now for first line, out in the in-house. And then we've got Hemabate. Okay, so let's say mom has high blood pressure. Instead of doing Methergin, they would probably do Hemabate. And Hemabate is another prostaglandin. It could do IM or IU, 0.25 milligrams. You could do it every 15 minutes to every 90 minutes, and you could give up to 8 doses. Okay, so you could do it more than once, but usually these medications work really well. If you need blood replacement, you will. Make sure you do a type and cross. If we have to ligate the vessels, we will do vessel ligation. And of course, our last resort, if the uterus does not cooperate and mom cannot continue to have her postpartum hemorrhage, is a hysterectomy. We also want to give her, as part of the medical management, antibiotics are obviously given to her to prevent infection. Okay. The good thing about Methergin is we've given it to her, it works, or we gave her, let's say, Cytotec, it worked, and we sending her to postpartum, and we have to keep an eyeball on her because she was a really bad bleed. We could, in postpartum, we could give her Methergin, okay? We could still give her Methergin PO, let's say 0.2 milligrams every 4 hours for like 6 doses, and do a 24-hour follow-up. We also do in-house, and I am happy that this book mentions it. We do in-house something called a balloon catheter, okay, for these really bad bleeds as well. and it's called a Bakri balloon, B-A-K-R-I. It doesn't go specifically on the Bakri balloon, but it does talk about the balloon catheter. And of course, you have to have an ultrasound they're also doing, okay? At the same time here, it's usually about a 24 French catheter, and you're inserting 500 cc's to fill the catheter up with sterile water, okay? And that's putting pressure against the uterus for these bad bleeds, okay? So it's kind of doing like that bimanual compression, but you've got that catheter in that balloon filled with 500 cc's of sterile water in pressing against the uterus for these postpartum hemorrhage, just to make sure that, just so it has resistance, so it contracts, okay? Nursing considerations. So again, fundal massage, measure fundal height. Don't forget, you're still doing all of this because that's the organ that we are really, really worried about once mama delivers. Okay, fundal massage, measure fundal height. Obviously, we're going to have an IV access, 16 to 18 gauge, assess the lochia. Remember, we're doing check pad counts. Okay, make sure when she's changing her pad every 3 hours, we are assessing her pad count. Offer bedtime, vital signs, and obviously if she's respiratory, we are giving her oxygen by face mask, okay, for anything respiratory. Again, some key points, respiratory, postpartum, postpartum hemorrhage is the most common and most severe type of excessive OB blood loss. Hypovolemic shock is an emergency situation in which perfusion of body organs may become severely compromised, leading to morbidity or mortality rates for mothers. And we continue with involution. Now, involution is in normal postpartum, right? Was the state that the uterus goes back to pre-pregnancy state, right? So it involutes 1 to 2 finger breaths for every postpartum day. The opposite of involution is sometimes it gets stubborn and doesn't want to move my slide, is sub-involution. Okay, so involution, so this is the opposite of sub-involution that we're going to talk about in high risk postpartum, because now the uterus is misbehaving in sub-involution and doesn't want to involute, right? It's too relaxed and doesn't want to contract to come back to pre-pregnancy state like it should in the involution process. By the time that 7 to 9 days comes around, that uterus is nice and engaged in that pelvic cavity again where we can't feel it. So the opposite is our subinvolution. That is obviously the opposite of involution, incomplete return of the uterus to its pre-pregnancy size and shape, where the uterus shouldn't be palpated on assessment on a woman that's not pregnant. Okay, and remember, the uterus does go back to pre-pregnancy size and shape 7 to 9 days postpartum. So usually with subinvolution, mom goes to her, 4 to 6 week postpartum visit, and the uterus is still enlarged, it's still soft, and that is what subinvolution is, okay? Let's talk about some symptoms, okay? So subinvolution, still late postpartum hemorrhage. So this is 1 to 2 weeks after childbirth. Okay, she still has this late postpartum hemorrhage. And remember when I talked about the lochia, I talked about moving forward and the healing process, it gets better. So it goes from bright red, right, rubra, to the pink, light pink, serosa, and then it starts changing the color to alba, which is your yellow white. Okay, that process needs to happen. That is the process of the uterus, okay, getting better and healing. You don't want to still have hemorrhaging 1 to 2 weeks after childbirth, or excessive blood loss, or the lochia that fails what I just said to progress from rubra, serosa to alba. Okay, there's just one way to go, and it's healing and better, and that's the rubra, serosa, and alba. And then that lochia rubra that persists after 2 weeks. Now, a little bit, since we're going through the symptoms, a little bit about how do we enhance uterine involution. Okay, how do we do this? Breastfeeding is wonderful because it releases your natural Pitocin, natural form of Pitocin, which is oxytocin, early ambulation, and frequent voiding. Okay, this is so that that uterus will behave. Breastfeeding, so that enhances uterine involution, early ambulation, and frequent voiding. Now we're going to go through our medical management. And before we do that, some risk factors from subinvolution. And why this is happening. Some risk factors are a pelvic infection like endometritis that we will talk about, retained placental fragments. So uterine atony is the number one cause. And the second most famous is that retained placental fragments. You think that, at delivery, whether it was a vaginal delivery or C-section, the uterus is completely cleaned out, and then there's still some little fragments of placenta in there. And that will be enough for that uterus not to involute. And then proceeding on with our slide for medical management and nursing considerations, we have again Methergin, because we said in postpartum we can give Methergin, PO. Okay. Usually this prescription of Methergin is going to improve our uterine tone and finish completing that involution process. Okay, and like we said before, it's 0.2 milligrams. We could give every 6 hours, PO or IM, and we could do it for about 2 to 3 days. Okay, oral antibiotics. We're going to do bacterial culture. So we're going to culture the blood. We're going to do intracervical, and we're going to do intrauterine. Okay, make sure there's not an infection. Okay, cervical or uterine. So we're going to do blood cultures. We're going to do blood, intracervical, and intrauterine. And a D&E, okay, a dilation and evacuations to remove the retained placental fragments. Okay, mamas usually do very well. Another challenge in high risk postpartum is your DVTs. Okay, your thrombophlebitis. So it's a condition in which a blood clot, a thrombus, forms in one or more of the deep veins in your body. We're talking about blood, but it's one or more of the deep veins in your body, and that's a condition in which a blood clot, the thrombus, forms. Okay, this could be from, let's say, the fetal head during delivery, which traumatizes that pelvic veins. And it can occur as an extension of an endometrial infection. We're going to talk about endometritis next. So it can extend from an infection of the endometrial, which is the endometritis as well. Usually symptoms are going to present about 10 days or so after birth. Okay, usually if the symptoms present. And we will, a little before we keep going with the different types, a DVT. So obviously the thrombus that forms in the deep veins of the leg, and then you've got the normal blood flow, the DVT, and then of course there comes the emboli. Symptoms: we've got edema of the ankle and the leg. Mom will present with a low-grade fever, followed by chills and a high fever. We're talking about a high fever. We're talking about 104, 105. Pain, this is usually when walking, and pain's going to be in the lower legs, lower abdomen. We've got her peripheral pulses that will be decreased. She can complain of dyspnea. She can complain of chest pain, sweating, hypotension, change in the LOCs, and obviously involves a big risk of a pulmonary emboli. Yes, medical management and nursing considerations is obviously prevention, prevention, prevention. This is why postpartum, we want to get moms early ambulation, up and walking, so all that blood flow is circulating, increase her fluid intake, and obviously we want to obtain clotting factors or clotting times. Okay, so this is prevention, 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 but now that it's here, we have to treat it. So your initial treatment is continuous IV heparin, okay, 3 to 5 days of IV heparin, NSAIDs, non-steroidal anti-inflammatory, so ibuprofens, bed rest with the affected leg elevated. And if the symptoms, after the symptoms have decreased, okay, after, this is the initial treatment, heparin, NSAIDs, and bed rest. After these symptoms have decreased, we can get her fitted with elastic stockings when she's walking. And then she'll be sent PO anticoagulant. So let's say warfarin. So PO anticoagulants and blood thinners for 3 months or longer. And then obviously we're going to obtain our clotting times. And then before we move on, I want to make sure we go over the 3 different types. I'm going back to the first slide. DVTs are changes that can take place in the deep veins of the calf, the thigh, or the pelvis. And then these are your 3 types. Your superficial thrombophlebitis, which is palpable. Your femoral thrombophlebitis, which actually decreases pedal pulses. The femoral has pain, stiffness, swelling in the affected leg, and usually carries a positive Homan sign. Of course, Homan sign is a question mark because some hospitals do not allow healthcare providers to do Homan sign, but if they do, it usually is a positive Homan sign, and that's for femoral thrombophlebitis. And then your pelvic thrombophlebitis has an increase in temperature, chills, and usually the first sign is a pulmonary emboli. So I wanted to make sure that we went through the 3 types of DVTs, okay? And then we've gone through our symptoms, we've gone through medical management, and then the initial therapy, and then we said that if the symptoms continued, we fit mom for stockings. She'll be discharged home with PO anticoagulants, and she'll be obtaining clotting times on mom. So listen to your patients when they're in-house and you're taking care of them and they tell you that their legs hurt. Even if you don't see that it's inflamed, go ahead and order, have the primary, OBGYN that's taking care of mom, let them know what's going on so that they can order a Doppler before she goes home, a Doppler ultrasound to confirm that diagnosis. Even if you don't see the leg, sit her down, lay her in bed, look at her leg, and if she complains that she still has pain, I would get an order for a Doppler ultrasound because you want to be absolutely sure before she's discharged home that you've done, the best that you can, and that if she's complaining, then you've done diagnostics to find out what's going on. Always, always listen to your patients. And that leads us into endometritis, which usually occurs secondary to chorioamniotitis before birth. Remember the infection when mama ruptures? Sometimes mom will have an infection, and that is called chorioamniotitis. This usually becomes the most common cause of postpartum infection is the endometritis. Okay, and again, the infection is usually associated with C-sections and usually associated with chorioamniometritis. So it refers to an infection of the endometrium, which is a lining of the uterus. The bacteria gains access to the uterus through the vagina and enters the uterus either at the time of birth or during postpartum. And there you could see, your yellow being, of course, your bacteria, and then, of course, the lining of the uterus, okay, inflammation, infection of the endometrium, which is the lining of the uterus. Symptoms of endometritis, again, risk factors. C-sections, retained placental fragments, prolonged rupture of membranes, again, that can lead to endometritis. Sometimes multiple sterile vaginal exams after rupture of membranes, and a prolonged labor. Okay, and that leads us into our slide that you are seeing in front of you, which is symptoms of endometritis. I'll tell you, usually moms complain of a really bad backache, headache, and an increased pulse. And a lot of times those three come together: a backache, a headache, and an increased pulse. At the same time, they've got white blood cells that are 20 to 30,000. They have a rise in temperature, again, 24 hours postpartum. Their abdomen is tender. And usually that rise in temp, again, most common is a 2nd to the 5th day postpartum. Their abdomen is tender. They'll have strong after pains. And those strong after pains is that uterus, having those contractions coming back, involuting, coming back to pre-pregnancy state. They do get stronger as the number of deliveries increase, okay? The more babies that they deliver. And lochia foul odor with lochia. Usually the lochia is going to be dark brown, and anything dark brown postpartum, there's an infection attached to it. And that's, symptoms for endometritis. And of course, because the uterus is not well contracted and it's painful to touch, usually patients with endometritis have a delayed involution process. Okay, so what are we going to do? Medical management and nursing considerations. Well, we're going to do culture of the lochia. Okay, we've got to get the culture. We've got to get an ultrasound. Okay, we'll do a chest x-ray just to make sure this infection hasn't gone anywhere else. We're going to put her on antibiotics until she's afebrile, which is usually 24 to 48 hours. And she's going to have white blood cells that are normal. Okay, so we will put her on antibiotics until she's afebrile. And it'll take a good 24 to 48 hours of an IV broad spectrum antibiotic. Those are your cephalosporins, your penicillins, your clindamycins, your gentamicins, analgesics, antipyretics, increase in fluids. Yes, meticulous, frequent perineal care, because she already has an infection. So we want to make sure that she's taking care of her infection, and we don't want her to have either a bigger, infection now. So frequent perineal care. And of course, don't forget about your vital signs and your lochia. You're assessing your lochia as well, and you are doing your fundus checks. Okay, make sure that uterus's midline is firm, and it's involuting. Okay, 1 to 2 centimeters below the umbilicus for every postpartum day. And you want to make sure to promote the flow of lochia that you put mom in a semi-Fowler's position. You encourage her to sit up. Okay, and it promotes drainage. Also, walking is good for her. Okay, that's why increasing fluids, walking will be also good for her, because you're getting rid of that infection. And that leads us into another challenge in postpartum, which is UTIs. Okay, and just keep in mind, urinary retention occurs when the bladder is unable to empty. And because she's had this baby in utero, and 97 to 98% of the time, baby is head down, bladder's been compressed by this infant's head during birth. So sometimes mom will have several UTIs throughout her pregnancy, okay, because the bladder is already compressed by the infant's head, okay, during birth. So urinary tract infection, so you've got the kidneys, the uter, the bladder, and the urethra. Cystitis is an infection of the lower uterine tract caused usually by E. coli. And this occurs in about 2 to 4% of postpartum women have UTIs. We've got our pyelonephritis, which is the infection of the upper urinary tract that causes damage to the kidneys and impairs the function. Okay. In postpartum, if there's a postpartum infection, then usually it increases the chance of a UTI. Causes of a UTI, well, decreased bladder sensitivity, you've got increased bladder capacity, you've got bladder trauma at birth, you've got that increased diuresis that can cause a UTI as well. Some other predisposing factors or conditions is anemia, poor hygiene, and then some risk factors leading this mom to UTIs is having to get a Foley, a urinary catheter, and those frequent, even though they're sterile, but those frequent pelvic exams as well. Now, what are our symptoms? Overdistension of the bladder, frequent urination, burning, dysuria, and that frequent urination in small amounts, hematuria, that elevated temp, usually 101, flank pain, CVT, costovertebral tenderness, okay, costovertebral tenderness. Remember CVT, the backache. Chills, nausea, and vomiting. She also will have an increase in vaginal bleeding because it's an infection in the uterus, and the uterus needs to be nice and clean so it can have nice contractions, those after pains, so it can do the process, right? Could go through the process of involution. Now we also might have a boggy uterus, okay, a boggy fundus. So what do we do with management with UTIs? Well, as you know, antibiotics, okay, broad spectrum antibiotics for about 5 to 7 days, okay. Sometimes your amoxicillins, your ampicillins, okay, a broad spectrum antibiotics. Sometimes your true UTI meds, which is your microdantans. Increase in fluids, okay, water every hour, a little bit, 8 ounce, because it has to come out so that you can get rid of that infection. Okay, lots of fluids, clear fluids, water is the best every hour. Tylenol for pain. Women's do pretty well, and the uterus appreciates the urinary tract does appreciate when antibiotics are given. We kill the bacteria and mom is good. Okay. Mastitis. I love these atom pictures. These are all atom, and I love these pictures because this is a true, it really looks like this. And you could see the abscess, the inflammation, then you could see your abscess where it's at. So mastitis, an infection of the breast connective tissue, primarily in women who are lactating. It's almost always unilateral, one, okay, and usually develops well after that flow of milk has been established, which is usually 2 to 3 weeks postpartum, but it can occur any time during lactation. And usually the causative organisms are staph, E. coli, and your streptococcus. So what are we going to do for mom, symptoms before we do our medical management and our nursing considerations? Usually is, like I said, unilateral. So affected breast shows the localized pain, the swelling, the redness. She'll have a fever. The breasts are hard, they're red, they're tender, they have irregular mass, maybe in one, sometimes in both, but usually in one breast. fevers are 104. She'll have chills. Breast milk becomes scant. Her nipples, you could see that her nipples are cracked. There's pain and tenderness in the axillary lymph nodes as well. And then medical management and nursing considerations. What are we going to do for this mom? Is your broad spectrum antibiotics as well. So again, your penicillins, your cephalosporins, your diclocillins, your fludoxacillin. So let me spell that. Diclocillins, DICLOXACILLIN, and then your fludoxacillin. So FLUDOXACILLIN. But your penicillins and your cephalosporins are also famous for being a broad spectrum antibiotic. Breastfeeding does continue, okay, or pumping. And that does continue every 2 to 3 hours. That is the most challenging, but you need to continue. You need to empty your breast, okay, to get rid of those abscesses. Cold or ice compress, supportive bra until that pain subsides. Cold, 15 minutes on, 45 minutes off. And warm compresses right before she breastfeeds or she pumps is going to be very helpful for her. Okay, the cold and the ice is because, of course, she's got that headache now, in her breast, that it's painful. Okay, and ice, what does it do? It's a natural anti-inflammatory. But right before she breastfeeds, a few minutes before she breastfeeds, she puts her warm compress, and that's going to be helpful. And then again, analgesics, ibuprofen, and a lot of rest. Okay, rest when the baby rests. That concludes our high-risk postpartum lecture.